found to have abnormal liver tests. As you can see, the main abnormality here is raised ALT level of 2 to 3 times the upper limit of normal. Now, of course, this is rather non-specific. In fact, any chronic liver disease can give you this pattern. If you go to any medical or hepatology textbooks, you will see a long list of differential diagnoses, ranging from viral hepatitis, alcohol-related liver disease, non-alcoholic fatty liver disease, drug-induced liver injury, to rarer causes, including some immune diseases, vascular diseases of the liver, and also inherited diseases. If you encounter a patient with abnormal liver test and you do examination for all these potential differential diagnoses, the yield would usually be quite low, and also it would not be too cost effective to do things like that. And therefore, you should also be aware of the epidemiology of the disease locally. In the Hong Kong setting, I would say that a number of diseases would be more common, including chronic hepatitis B, alcohol, non-alcoholic fatty liver disease, and drug-induced liver injury. Mind you, drug-induced liver injury can present in a variety of ways. It can be hepatic pattern, it can be cholestatic pattern, it can be isolated jaundice, it can also cause hepatic steatosis. And therefore, regardless of the remember to ask about the drug history, not only about prescribed drugs, but also including recreational drugs, herbs, and supplements, which are so common in our locality. When you see a patient with abnormal liver test, the clinical approach would be no different from what you do when you encounter any other clinical presentations. We still need to go for history taking, paying particular attention to past medical history, drugs, family history, and risk factors of viral hepatitis. On physical examination, we particularly want to detect stigmata of chronic liver disease, which would point towards a more chronic disease. In particular, the patient would probably be having cirrhosis. At the same time, we also look for signs of portal hypertension. On physical examination, the signs would include splenomegaly, ascites, and in severe cases, you may even encounter caput medusae. For the initial investigation, we usually would check the hepatitis B surface antigen and anti-HCV antibody first. We would also like to have an ultrasound scan of the abdomen, which can tell us a lot about the disease, including whether there is any fatty liver, liver cirrhosis, features of portal hypertension, and of course, the presence of liver cancer. Now for this gentleman, we found that the HbSAg was positive, anti-HCV was negative, and the ultrasound scan showed normal liver echo texture, no HCC or signs of cirrhosis and portal hypertension. So we are talking about chronic hepatitis B. This is very common. According to the last systematic review and meta-analysis in 2016, we know that close to 300 million people worldwide had positive HbSAg, translating into a global prevalence of 4%. Hong Kong is here, so according to the latest data, we know that around 6 to 7% of the general adult population would have positive HbSAg. Of course, among individuals younger than the age of 30, the prevalence of HbSAg would be rather low, in fact, less than 1%, mainly because of universal vaccination. This diagram summarizes the natural history of perinatally acquired chronic hepatitis B. Now, mind you, perinatally is a key word. In Hong Kong or in most parts of Asia, so we know that most of our patients had perinatally acquired chronic hepatitis B. In contrast, if you work in Western countries, then many of the patients would have adult onset due to horizontal transmission, like sharing of needles or sexual exposure. Now, the main difference is that if a patient acquires HBV infection during adulthood, there would be a potent immune response, and therefore you wouldn't see the immune tolerance phase. In fact, the patient would immediately go into the immune clearance phase, and in 95% of the cases, the patient would be able to clear the virus completely with a loss of surface antigen. But we are working in Hong Kong, so we should be familiar with the perinatally acquired chronic hepatitis B. Now, because the baby acquires the virus from the mother, at that time the immune system is immature, and also the body would think that the antigens that it encounters during early childhood would be part of the body, and therefore the body would not fight against the virus, and that is the reason for the immune tolerance phase. During this phase, the HBV DNA would be very high because there's little immune control. And at the same time, the ALT would be normal. Even if you perform a liver biopsy, you will find very little natural inflammation or fibrosis. And during this stage, you will also see a positive hepatitis B E antigen. Now, there is a lot of variability, but typically between the age of 20 to 40 years, the patient would enter into the immune clearance phase. Now the immune system is mature enough to recognize that HBV is foreign, and therefore it would try to clear the virus. So there would be fluctuating HBV DNA level, fluctuating ALT level because of the inflammation when the body's immune system is fighting against the virus. Now, the natural history would depend on the severity and duration of this phase. In some lucky individuals, they may be able to mount an effective immune response, and therefore the patient would lose the E antigen, develop the E antibody. This is called hepatitis B E antigen seroconversion. And the HBV DNA would come down, and the ALT would also become normal again. So the patient would become an inactive carrier, and the prognosis in general would be good. However, some patients would be less fortunate, so they still fight against the virus, but the virus remains active, and therefore there would be prolonged natural inflammation in the liver. So sometimes it may be persistently inflamed, but more often than not, there would be fluctuation in the ALT over time. Regardless, over time, the patient would sustain liver injury, so much so that there would be accumulating liver fibrosis, and finally, to the stage of liver cirrhosis and liver cancer, or liver decompensation. Now, although we say that hepatitis B E antigen seroconversion is good, but we know that this is not absolute. So on average, around 10 to 20% of individuals with negative E antigen will still have active viremia and also active hepatitis. In those individuals, there would also be a risk of disease progression towards cirrhosis and liver cancer. And some people call that the reactivation phase, or some people would call that E antigen negative active phase. In any case, the second and the fourth case, or the second or the fourth phase would be when the virus is active, when there is natural inflammation, and therefore treatments should be considered. When you encounter a patient with chronic hepatitis B, you need to answer 3 questions. You want to see whether the virus is active, and for that, the test would include the E antigen and also the viral load, the HBV DNA level in the serum or plasma. You want to know whether the liver is inflamed. Of course, you can answer this question by doing a liver biopsy, but you cannot do it every 6 months. And therefore, the marker that we rely mostly on would be the ALT level. Finally, we want to see how much injury the patient has sustained before seeing you. So we want to know whether there's any liver fibrosis. We want to know whether the patient has already got cirrhosis. Again, you can use liver biopsy to make the diagnosis, but nowadays we have other non-invasive tests to assess the severity of liver fibrosis. This diagram summarizes the indications for antiviral therapy. There are 2 main indications for antiviral therapy. First would be when the patient has persistently elevated ALT level, indicating there is ongoing liver injury, inflammation, and you want to prevent further disease progression. Alternatively, even if the patient has normal ALT now, if the patient has already got evidence of significant liver fibrosis or cirrhosis, again, you cannot allow the liver disease to worsen anymore. Of course, the use of antiviral therapy is to suppress HBV DNA, and therefore this would be a prerequisite. If the virus is no longer active, it is doubtful if antiviral therapy will still make a difference. There is another indication for antiviral therapy, slightly different. This is for prophylaxis. It is when the patient requires potent immunosuppressants or cancer chemotherapy. In those cases, even if the virus is not active now, you're worried about HBV reactivation, and therefore you have to provide the patient with antiviral prophylaxis. Now, I wouldn't require you to remember all the drugs that we have in the market, but you can divide the antiviral drugs for chronic hepatitis B into two main classes. The first class would be PEG interferon alpha 2A. It is an immunomodulatory agent to stimulate the immune system to fight against the virus to clear the HBV from the body. It is given subcutaneously, and the treatment duration is 48 weeks. Now, because of the immune response, there are numerous side effects. Many are immune-driven, like fever, headache, myalgia, but some people may also have thyroid dysfunction. Some people may have cytopenias or mood disorders. On the whole, PEG interferon only has moderate viral suppression, but because of the immune modulatory effect, it can enjoy a higher rate of E antigen seroconversion of 30 to 40% in 1 year. And also, although you may not see that in 1 year, but upon follow-up, up to 10% of people treated with PEG interferon may lose the surface antigen. So in medical terms, this is closest to a cure of the infection. The durability is good, meaning that if the patient has achieved E antigen seroconversion or surface antigen loss, and then you stop the treatment, the majority of cases can maintain the treatment response. On the other side, you also have the oral nucleoside or nucleotide analogs. So those are the oral antiviral drugs. On the whole, they have the benefit of having very few side effects, and they are very potent in terms of viral suppression. In fact, by 5 years of treatment, if you use the current first-line agents, more than 95% of cases should have complete viral suppression. However, because the oral drugs only suppress viral replication, they don't have immunomodulatory effect, and therefore in 1 year, only 15 to 20% of individuals can have E antigen seroconversion, and by 5 years, only 50% can do that. And the surface antigen seroclearance rate will be very low, less than 1% per year. And therefore, the treatment may be indefinite and the durability is modest. In fact, more than half of the patient would have a relapse of the disease after cessation of oral drugs. Nowadays, we are also interested in preventing new infection because you should not just focus on treating the existing patients. Preventing new cases is also very important. Now, for mother-to-child transmission, the most important preventive measure would be birth dose HBV vaccination. And if the mother is HBsAg positive, we also provide passive immunization, provide the baby with hepatitis B immunoglobulin at birth. So the antibody would bind all the viruses in the circulation and therefore preventing the infection from becoming chronic. Now, there is another new development. A few years ago, several observational studies and also a major randomized control trial published in the New England Journal of Medicine indicates that if the mother is having chronic hepatitis B and at the same time high viral load, the HBV DNA is more than 200,000 international units per ml, we know that even with birth dose vaccination or hepatitis B immunoglobulin, still a proportion of babies would become infected nevertheless. And therefore, in this setting, the use of perinatal tenofovir would be effective in preventing transmission. In fact, in those clinical trials, the transmission rate would be 0%. How do we do that? So for women with high viral load, by 28 to 32 weeks of gestation, we will start the drug, and then until 4 to 12 weeks after delivery. Apart from that, we should also prevent horizontal transmission. So we should vaccinate high-risk groups, such as injection drug users and men having sex with men. We should promote safe sex practice and avoid needle sharing. And finally, we should guarantee that there are safe blood products. In Hong Kong, this is done rather well, but in other countries, this may be less so. Now, apart from hepatitis B, another chronic viral hepatitis obviously would be chronic hepatitis C. So worldwide, around 71 million people were infected in the year 2015 with a global prevalence of 1%. In Hong Kong, it is not as common, but this is still something important that we should know something about. In Hong Kong, if you look at blood donors, the prevalence rate is less than 0.1%. But it doesn't mean that the disease doesn't exist in our locality, because if you look at drug users, 40% of the individuals would be infected, and among people with history of blood transfusion, 8.5%. And therefore, you should recognize these two high-risk groups, drug users and also people with prior blood transfusion. Now, if you want to be more exact, we are talking about people who had blood transfusion before 1990. The hepatitis C virus was discovered in the year 1989. And in fact, a couple of years ago, the discoveries of HCV received the Nobel Prize for this important discovery. And because of that, after the year 1990, we already had the tool to screen the blood products. And therefore, nowadays, the risk of getting the infection through blood transfusion would be minimal. Now, if you treat a patient with chronic hepatitis C, the most important concept is called SVR, which represents sustained virological response. SVR is defined as undetectable serum HCV RNA 3 months or more after cessation of treatment. Unlike hepatitis B, for hepatitis B, you can only suppress the virus, but for hepatitis C, you can eliminate, so you can eradicate the virus from the body. So this is very important, because if the patient has achieved SVR, the patient is cleared of the infection. But mind you, clearing the infection is not equivalent to clearing of the disease, because over the past several decades, the patient may have already become cirrhotic, and therefore the patient will still be at risk of developing complications. On the other hand, if the patient can achieve SVR before developing cirrhosis, the risk of complications would be minimal. In fact, according to current guidelines, if the patient does not have cirrhosis and has achieved SVR, you don't even need to monitor those patients or have a further follow-up. So another reason why SVR is important is that even among patients with advanced fibrosis before treatment, after achieving SVR, the risk of HCC and cirrhotic complications would be markedly reduced. So this is saving lives. How do we treat HCV? If you talk to me maybe 10 years ago, I would still be talking about the use of PEG interferon and ribavirin. But nowadays, we don't need to do that, because we have already known a lot about the life cycle of HCV. Okay, this is a paper from Nature Medicine. You obviously don't need to know the details, but this is just to tell you that there are 3 sites that are particularly important in terms of viral replication. Now, NS represents non-structural protein. So NS3 and NS4A complex would be the protease. The NS5A would be responsible for viral packaging, and the NS5B is actually the polymerase of the virus, resulting in the replication. So it turns out that if you inhibit these steps, you can effectively stop HCV replication. And people subsequently found that if you stop replication for an enough period, the virus can be cleared. Okay, you don't need to know anything about this slide, but what you want to know is that the drug that we are using to treat HCV infection would be called direct-acting antivirals, or in short, DAAs. And you also need to know that they are oral drugs with minimal side effects. They can be given for 8 to 12 weeks, and then you can achieve SVR in more than 95% of cases. Now, for the HCV drugs, they can be divided into pan-genotypic, meaning that you can treat all the viral genotypes, or some may be genotype specific, meaning that the drugs are active against some genotypes of HCV, but not all. And therefore, if you use the wrong drug to treat a wrong genotype, you are going to induce resistance without clearing the virus. Okay, now obviously, if cost is not an issue, there's no reason to consider genotype-specific drugs, and you can use pan-genotypic drug to treat every patient, achieving a very good response. However, in Hong Kong, cost is still a consideration, and therefore occasionally you will see doctors choosing a genotype-specific drug to treat the infection. Next, I would like to talk about another very important condition called fatty liver. There are two main causes of fatty liver, including non-alcoholic fatty liver disease, which is related to obesity and metabolic disorders. We also have alcohol-related liver disease, obviously due to excessive alcohol consumption. There are also less common causes of fatty liver, so including the use of drugs like systemic steroids, methotrexate, and tamoxifen. Now, hepatitis C virus itself can also induce steatosis. Some hereditary diseases like Wilson's disease can also cause hepatic steatosis as well. Last year, you had the obstetrics module. You know that there is a condition called acute fatty liver of pregnancy. Of course, it is quite rare and it can only occur during late pregnancy. Curiously, rapid weight loss can also induce fatty liver. This is because if you lose weight very rapidly, there can be, the body would respond by burning the fat, the subcutaneous and also visceral fat in the body, and this would generate a lot of circulating free fatty acids. When the free fatty acids go into the liver, it would cause fatty liver. Okay, so that's why when you go to some low-income countries, such as those in Africa, sometimes you may encounter children with big tummy. And if you feel the abdomen, there would be hepatomegaly. So this is a condition called kwashiorkor, and also this would be the reason underlying the hepatomegaly. For non-alcoholic fatty liver disease or NAFLD, it is a spectrum of disease ranging from non-alcoholic fatty liver, or some people call that simple steatosis, when you only have fat in the liver without any necroinflammation, no liver injury, and the patient is unlikely to develop liver complications. But 10 to 20% of all fatty liver patients may have non-alcoholic steatohepatitis, or in short, we call it NASH, and that is when you also have necroinflammation and tissue injury. Like all chronic liver diseases, if you have inflammation, you would have progressive liver fibrosis, and finally, to liver cirrhosis. Non-alcoholic fatty liver disease is important because it is common in Hong Kong. Close to 30% of the general adult population would have fatty liver disease. And like other metabolic conditions, it is more common in men than women, and also it increases with age. For women, the metabolic complications typically would develop after postmenopausal years. And therefore, for fatty liver, it is no different. Now, apart from it being common, it is important because it can also cause severe liver complications. In the United States, by the year 2016, fatty liver disease has already overtaken chronic hepatitis C as one of the leading indications for liver transplantation. Currently, it is number 2, but if you look at women only, it is already the number 1 indication for liver transplantation in the United States. Now, people would argue with you that this doesn't mean that it is the most common cause of liver failure, because you also need to understand that for alcohol-related liver disease, many patients are not eligible for liver transplantation because they are still drinking like crazy, and therefore they would be excluded from the transplantation program. And if you count the total number of cases with liver failure and liver decompensation, I would still say that alcohol-related liver disease is still leading in the Western countries, maybe less so in Asia. The diagnosis of fatty liver is based on the detection of hepatic steatosis, either by imaging, blood biomarkers, or histology. But in most clinical settings, ultrasound scan would be the main modality for you to make a diagnosis of fatty liver. Under ultrasound scan, there are 3 features. The liver would look rather bright, so much whiter than the adjacent kidney as shown here. There would also be deep attenuation of the ultrasound signal, and therefore the deeper tissues would be blurred, and therefore you also see vascular blunting. At the same time, you need to exclude excessive alcohol consumption and other liver diseases. For the management, like any metabolic disease, lifestyle modification is the most important, but we also have some pharmacological treatment, and also if the patient is severely obese, bariatric surgery would also reverse many of the changes of the liver. For pharmacological treatment, there is actually no registered drug for the treatment of steatohepatitis, but the international guidelines have endorsed 2 existing drugs in the market to treat steatohepatitis, mainly because there have already been multiple studies indicating that they can reduce liver fat and inflammation. Vitamin E is an antioxidant, so it would reduce inflammation. However, metabolically, it is neutral, so it would not affect insulin resistance, and also it has some uncertain effects on the cardiovascular system and other malignancies. Notably, some observational data suggest that high-dose vitamin E may increase the risk of prostate cancer, but this is rather controversial. Pioglitazone is an anti-diabetic drug. It is a PPAR-gamma agonist. It works by its insulin sensitizing effect. Again, it would reduce liver fat and inflammation. The main side effects would be weight gain and fluid retention, and therefore it is contraindicated to people with severe heart failure. And there are also observational data suggesting that it may increase the risk of urinary bladder cancer. Again, this is controversial, but at least there are some potential risks. Okay, after talking about some common chronic liver diseases, let's talk about an acute liver disease. This is a 20-year-old male university student who traveled to Thailand 2 weeks ago. He presented with poor appetite, malaise, jaundice, and thickened urine, and this is what you see. This time you see high bilirubin level and also very high ALT level of 2000. This is acute hepatitis. Now, the causes of acute hepatitis would be somewhat different from the causes of chronic hepatitis. So for one thing, hepatitis A and E would be the major causes of acute hepatitis. So, but of course, you have to recognize that although hepatitis B and C can cause chronic hepatitis, some people can also get it now, and therefore it can be an acute hepatitis. More than that, some patients may be having chronic viral hepatitis, but now they have a disease flare, and the presentation will be exactly identical to that of acute hepatitis. Again, don't forget drug-induced liver injury. For alcohol, it would be a condition called acute alcoholic hepatitis, and in this situation, the ALT is seldom very high, but because alcohol would have damage to the mitochondria, and we know that AST is residing in the mitochondria of hepatocytes, and therefore for alcoholic hepatitis, typically the AST level is higher than the ALT level. Regarding the rarer diseases, autoimmune hepatitis, Wilson's disease can also give you acute hepatitis. And sometimes, although acute cholangitis is due to bile duct obstruction, but we know that in some severe cases, the patient may also present with predominantly hepatic pattern. When you see a patient with acute hepatitis, again, you have to ask about past medical history, drugs, alcohol, risk factors for viral hepatitis, and the family history. On physical examination, I would look for stigmata of chronic liver disease. Mind you, this may be an acute exacerbation of a chronic condition, and therefore this is still useful. Now for the initial workup, of course, checking for acute viral hepatitis is important, and you know that immunoglobulin M is for acute infection, whereas immunoglobulin G is for any exposure, so it can also be due to chronic diseases. So in any case, for hepatitis A, IgM anti-HAV, hepatitis E, IgM anti-HEV, very simple. Now, what is less simple would be hepatitis B. So you know HBsAg is the hallmark of HBV infection, but it is not always the case. In acute hepatitis B, the patient may lose the surface antigen, and therefore the only marker that you may detect may be IgM anti-HB core. If you forget to check this marker, you may never make the diagnosis of acute hepatitis B, and the reason for acute hepatitis B can remain a mystery. Now for HCV, unfortunately, we don't have the IgM, and therefore we only have the total or IgG anti-HCV. But if a patient has acute hepatitis C, it may take up to 12 weeks for the anti-HCV to turn positive. So what should we do? There are two things you can do. First of all, in suspected cases, you may repeat anti-HCV 3 months later. Alternatively, if you have a clear-cut history of exposure, for example, if you have a colleague with a history of needle prick injury, or if you have people with risk factors like injection drug use or sexual exposure, and now you see some hepatitic activity, then the test you can do would be the HCV RNA. We are not doing HCV RNA for all patients with abnormal liver test, mainly because of its cost, because it is based on polymerase chain reaction, which is considerably more expensive than antibody test. Now, if all the tests are negative, consider performing anti-nuclear antibody, anti-smooth muscle antibody. These are for autoimmune hepatitis. And finally, consider liver biopsy to make the diagnosis. These are updated data from Hong Kong, essentially telling you a number of interesting observations. First of all, acute hepatitis is becoming less common nowadays. So this is in the 1990s, and now the number of acute hepatitis has dropped by more than two-thirds. Okay, and secondly, among the acute viral hepatitis, as mentioned, hepatitis A and E would be the most common causes. Now, it is difficult to discern whether hepatitis E or hepatitis A are more common. For some period in the early 2010s, you can see that hepatitis E would be more common, mainly because of herd immunity. Many people would have antibody to hepatitis A, and therefore only people who travel to other areas or having raw food consumption would have acute hepatitis E. However, things have changed after the year 2015. This is because there are isolated outbreaks in Hong Kong. First of all, the herd immunity has declined over the years. And secondly, there are specific outbreaks. So in particular, in Hong Kong, there are men having sex with men who would have some sexual practices that predispose them to develop acute hepatitis A. So these are the things that you need to be aware of. This is the CDC recommendation on hepatitis A vaccination, mainly in high-risk individuals. So those are the high-risk individuals, injection drug users, people with unstable housing or homelessness, men having sex with men, people who are recently incarcerated, and for people with chronic liver disease, this is not a risk factor for acute hepatitis A, but we know that if they acquire acute hepatitis A, they are more likely to develop liver failure or succumb from the disease. And therefore, current recommendations is that they should receive HAV vaccination. Okay, let's pause for a while and let you have some active participation. You can use the chat function to tell me your answer. Now, when you have different serologies, you can have different combinations, and it is important for us to understand what it means. Okay, let's have this first scenario. Scenario A. If you have a patient with high ALT level, let's say 500, and a negative surface antigen, negative IgM anti-HB core, what do you think this represents? Is this not hepatitis B, acute hepatitis B, or chronic hepatitis B? What do you think? Okay, you can just type 1, 2, or 3. Okay, very good. This is not hepatitis B, so the answer is 1. Now, second situation, positive surface antigen, negative IgM. What is it? Not hepatitis B, acute hepatitis B, or chronic hepatitis B? Okay, so this is chronic hepatitis B. The patient has positive surface antigen, so but negative IgM. IgM is the hallmark for acute infection. Scenario C, also rather simple. Negative surface antigen, but positive IgM anti-HB core. What is it? Is it not hepatitis B, acute or chronic hepatitis B? Okay, very good. This is acute hepatitis B. Now, finally, this is trickier. What if the patient has both positive surface antigen and IgM anti-HB core? What is it? Okay, anyone, what do you think? Okay, in fact, this is a tricky case. So in this scenario, it can be acute hepatitis B before losing surface antigen, or in 5% of cases, the patient may not be able to lose the surface antigen. Alternatively, we know that in some patients with quite severe acute exacerbation of chronic hepatitis B, they can also generate the IgM. Now, the question is, how do you distinguish between the two then? There are two main methods. First of all, you can do an ultrasound scan. If there are features of liver cirrhosis, you know that this is likely to be chronic, unless there is another explanation for the presence of liver cirrhosis. Secondly, you can repeat the blood test 6 months later for the HbSAg. If this is acute hepatitis B, in 95% of cases, the surface antigen would become negative within 6 months. On the other hand, if this is chronic hepatitis B, the majority of cases should remain surface antigen positive. Now, you may argue, what if the patient actually had acute hepatitis B but failed to lose the surface antigen? We know that 5% of the individuals would be like that. Then my simple answer is that if by 6 months the HbSAg remains positive, by definition, the patient has become chronic, and therefore you have to manage the patient as chronic hepatitis B. Okay, very good. This is the diagram representing the serology of acute hepatitis B. So this is to illustrate what the window period means. Now, of course, the patient originally would still have HbSAg, but they would be able to mount an immune response to clear the surface antigen. On the other hand, the IgM would become positive. And if the patient has already lost the surface antigen, then this is called the window period, because this is a time when you can only detect the infection by the antibody. Okay, next patient, a 70-year-old woman, non-drinker with type 2 diabetes, hypertension, presenting with right upper quadrant pain, jaundice, and fever for 1 day. This is a cholestatic pattern with high bilirubin and high ALP level. Quite often, the ALT would also come up a bit, usually not as severe, but as mentioned, in some severe cases, ALT can be particularly high. So this is the Charcot's triad. You know that this is acute cholangitis. For further workup, we need to check the white cell count. You want to see whether the patient is in DIC, so you want to know the platelet count. You want to know the clotting profile. We also check for renal function tests, because in severe infection, people can develop acute kidney injury. Blood culture, obviously important. We would do the urgent ultrasound scan of the abdomen, mainly to look for biliary dilatation, because it is quite difficult to look inside the bile ducts. We want to look for gallbladder stones and also liver abscess. Now, if you are unable to arrange an urgent ultrasound scan of the abdomen, you can also contact the on-call endoscopist, because acute cholangitis is actually a clinical diagnosis. Okay, so as mentioned, for the liver biochemistry, sometimes it can be atypical, and also ultrasound scan may not be able to see the biliary dilatation anyway. And if you have an ultrasound scan, that would be good, because we still want to see whether there are abnormal anatomies and whether there are abscesses inside the liver. But if not, some endoscopists may be willing to go right away for ERCP. So keep that in mind. Here are the principles of acute cholangitis management. We need to resuscitate the patient because they are often in shock. We need to monitor the vital signs closely, provide broad spectrum antibiotics, and also cholangitis is like an abscess. So it is bacterial infection of an enclosed system. And in this case, the enclosed system is the biliary system. So urgent drainage is very important. Usually in the acute situation, we try not to perform a prolonged procedure to do sphincterotomy, clear all the stones, because a prolonged procedure may risk further septicemic shock, particularly if you inject a lot of contrast, resulting in a backflow of the bacterial toxin. And therefore, our primary aim is to achieve quick relief of the biliary obstruction. This can be achieved through ERCP by inserting a biliary stent or a nasobiliary drain. Next patient, A 60-year-old man, chronic drinker of 2 bottles of beer per day, known to have chronic hepatitis B for years, with normal liver biochemistry. The E antigen was negative, but the HBV DNA was high, 500,000 IU per ml. The ultrasound scan showed coarse liver echo texture, no portal hypertension, but the fibro scan showed high liver stiffness of 22 kilopascal. So this is a confirmed case of liver cirrhosis. The question is what to do. When you see a patient with liver cirrhosis, there are 3 things you can do to improve the survival. First, we treat the underlying etiology. We know that even by treating the underlying etiology, in some cases, the cirrhosis can regress. So from cirrhosis to no cirrhosis, this is very important, not to mention the prevention of cirrhotic complications. In this particular case, he needs to quit alcohol and also start antiviral drug for HBV. The second thing you can do is to provide HCC surveillance using 6-monthly ultrasonography and also alpha-fetoprotein. Now, we also perform a GI endoscopy for varices surveillance. Okay, in this particular case, ultrasound scan 6 months later showed a 5 mm hyperechoic lesion in the right lobe of the liver. Okay, so here, what will you do? Will you repeat ultrasound scan in 4 months, perform a triphasic CT scan of the abdomen, MRI scan of the abdomen with contrast, or a PET scan, positron emission tomography? So again, you can use the chat function to tell me what you would like to do. 1, 2, 3, or 4. Okay, the majority of you chose a triphasic CT scan of the abdomen. Okay, let me show you the answer. Okay, first of all, HCC remains important in Hong Kong. So even though nowadays we have HCC surveillance, we have many effective treatment for HCC, we know that the population incidence rate is actually declining quite nicely. However, if you look at the Hong Kong Cancer Registry data, you will realize that the liver cancer incidence and mortality have not changed at all in the past 10 years. You may wonder why. So in fact, the incidence rate has come down. The main issue is that we are experiencing population aging. Therefore, we have increasing population size, and also we have more older people in the Hong Kong community. And therefore, effectively, the total number of cases have stayed unchanged. So around 1,800 new cases of HCC per year, and among them 15,000 would die. And therefore, the majority of patients with liver cancer would die from the disease. This is very important. This is the American guidelines on when to start HCC surveillance. So this is based on cost-effectiveness analysis, telling you that if the patient is cirrhotic, then if the annual incidence of HCC exceeds 1.5%, you should start surveillance. For selected groups of non-cirrhotic patients, then you would have a lower threshold. But in any case, the answer is very simple. You would do HCC surveillance if the patient is cirrhosis. Okay, so if they have cirrhosis of any etiology. But we also know that in some etiologies, such as hepatitis B, people can develop HCC without having cirrhosis first. So for example, if you have Asian male older than the age of 40, Asian female older than the age of 50, or for Africans, they may even develop HCC even earlier. So for those individuals, even without cirrhosis, you will start HCC surveillance. Now, another important point is that some patients would not benefit from HCC surveillance, because think about it, when you have had your public health, community health, community medicine module last year. So for any screening, it is not just early diagnosis of a particular condition. You also need to answer what you can do after making the diagnosis. Of course, a cancer diagnosis would only be meaningful if you can provide the patient with curative treatment. And therefore, if the patient has limited life expectancy, if the patient for any reason is unsuitable for curative HCC treatment, it is very doubtful whether you are doing any good by performing HCC surveillance. Now, for the same reason, if the patient has Child-Pugh class C cirrhosis, many of the curative treatment cannot be offered, with one exception, and that is liver transplantation. And therefore, if the patient remains a liver transplant candidate, we should still continue HCC surveillance despite the fact of hepatic decompensation. Okay, so for HCC surveillance, we do abdominal ultrasonography, but we need to understand that in obese individuals or in patients with cirrhosis with multiple regenerative nodules, the performance of abdominal ultrasonography can be quite poor. In our setting, we do a lot of alpha-fetoprotein testing, but it is not a good biomarker. In fact, there are false positive results, particularly when the ALT is high or when the patient is pregnant. There are also false negative results because the sensitivity is only 60 to 70%. And therefore, in 30 to 40% of liver cancers, the AFP would be negative. And therefore, in some Western guidelines, if you have already got abdominal ultrasonography, it is highly doubtful whether alpha-fetoprotein would have any additional benefit. However, in the Hong Kong setting, because we don't have enough radiographers and we cannot guarantee 6-monthly ultrasound scan, and therefore some screening is better than no screening, we are still doing AFP. So you may also ask why we do 6-monthly surveillance. This is because before liver resection became possible, people did some observational studies to study the natural history of HCC, and they realized that the average tumor doubling time is around 140 days, and therefore assuming that the ultrasound scan may miss a lesion less than 1 cm in size, then even 6 months later, the lesion should still be less than 2 cm in diameter and therefore readily treatable. And that's the basis for recommending 6 months-based surveillance. This is the European guideline on what to do when you see a lesion on imaging. So this answers the question I posed just now. You only consider one condition, and that is the size of the lesion. When the lesion is less than 1 cm in size, because first of all, it is more likely to be benign, and secondly, even if you perform a cross-sectional imaging, you may not cut the lesion properly. It may be tangential, you may not see it well, and therefore the diagnosis may remain uncertain. And therefore, current guidelines say that if the lesion is less than 1 cm in size, then we would repeat the ultrasound scan in 4 months, and then to see whether there's any interval change. On the other hand, if the lesion is bigger than 1 cm in size, it would be a good idea to have a cross-sectional imaging. For practical purposes, you can consider CT and MRI to be identical. So if it is positive, you treat it as such. Of course, if the diagnosis remains uncertain, you can consider biopsying the lesion. Okay, so this is triphasic CT scan of the abdomen. You can see that a typical HCC would give you arterial enhancement and also portovenous washout. Okay, why is this the case? This is because of the differential blood supply of different liver lesions. So you know that for the liver parenchyma, it is 80% supplied by the portovenous system, whereas 20% supplied by the hepatic artery. On the other hand, it is the other way around for HCC. For HCC, the majority of the blood supply comes from the hepatic artery. And therefore, when you perform a cross-sectional imaging, during arterial phase, the HCC would be lighted up first. Now, during the portovenous phase, this is not to say that the contrast has already totally gone from the HCC. It is not like that. But it is during the portovenous phase that the adjacent liver parenchyma would be lighted up. And therefore, by comparison, the liver lesion would appear hypodense. And that's why you would see the typical feature of a portovenous washout. Okay, this would be the final case we discussed today. The same patient, 60-year-old patient who drank alcohol and also had hepatitis B-related cirrhosis. We asked him to quit alcohol and started him on entecavir. The HBV DNA became undetectable. But 1 year later, he was admitted to the hospital because of abdominal distension. On examination, there was shifting dullness suggestive of ascites. Now, this is new onset ascites. Do not say that if a patient has new onset of ascites, it is just cirrhosis and therefore nothing needs to be done. It is actually unusual to develop liver decompensation when the underlying etiologies are well controlled. And therefore, there are two important complications you must exclude for the first episode of ascites. First, the development of HCC plus or minus portal vein thrombosis. And secondly, spontaneous bacterial peritonitis. SBP, this patient has SBP as evidenced by a high neutrophil or polymorph count. So we diagnose SBP when it is over 250 cubic millimeter. And in this case, the acidic fluid also blew E. coli. So we gave him IV cefotaxime for 5 days and also started him on long-term oral norfloxacin prophylaxis. This is because if left untreated, 70% of the individuals would have a recurrence of SBP, and we know that every episode of SBP can kill the patient. So long-term prophylaxis is important. For the management of ascites, salt restriction is the most important. You may see doctors recommending water restriction, but in fact, salt restriction is effective. Water restriction is not very effective in preventing ascites. In fact, according to current guidelines, you should only ask for water restriction when the patient starts to develop quite a bit of hyponatremia, typically less than 125 millimole per liter. Now, we would use diuretics. So spironolactone is the first line. You may also add furosemide with a synergistic effect. For gross ascites, the treatment would be large volume paracentesis. So we stick a needle in to drain the fluid out. Now, for refractory ascites, we consider shunting procedures. Nowadays, we usually perform transjugular intrahepatic portal systemic shunting. And in any case of hepatic decompensation, we consider liver transplantation. When you manage a case of ascites, we monitor the body weight because rapid changes in the body weight more faithfully reflect changes in the fluid status than many other things that you can do. Okay, so this is the initial lecture on some common chronic liver diseases and acute liver diseases. And later on, I will also have another session on case discussion. And this would be on the various cirrhotic complications that people tend to ask you in written papers. Okay, so this is the end of the lecture. And if you have any questions, please feel free to use the chat function, or you can unmute yourself and ask questions. Okay, I see a question on occult HBV infection. Now, occult HBV infection is defined as negative surface antigen, but you can detect HBV DNA anywhere in the body. So it can be in the blood, it can be in the liver or other tissues. Okay, but for practical purposes, you would unlikely perform a liver biopsy just for the sake of detecting occult HBV infection. And therefore, the most common way of diagnosing or suggesting this diagnosis would be for a patient with negative surface antigen, but positive anti-hepatitis B core antibody, because this is a marker of prior infection. And you can assume that a proportion of these individuals may still carry the occult infection. Now, of course, you don't need to diagnose occult HBV infection in all cases. In the majority of cases, it doesn't matter at all. However, if you are going to use very potent immunosuppressants, or if you use very potent cancer chemotherapy, then sometimes you would want to make this diagnosis because you are worried about HBV reactivation. Now, even with the regular cancer chemotherapy, the risk of occult HBV reactivation is rather rare. And therefore, according to current guidelines, there are two situations in which you need to check for occult HBV infection. The first is when you use anti-CD20 monoclonal antibody, or we call it B-cell depletion therapy. So one common example would be rituximab. We know that it can reactivate occult HBV infection. The second situation is when you are going to perform hematopoietic stem cell transplantation. Again, because of the potent immunosuppressive effect, even occult HPV infection can be reactivated. But for the other common things that you do, like if you use azathioprine, or if you are using biologics for inflammatory bowel disease or rheumatoid arthritis, there are already data showing you that the rate of reactivation is actually quite low, and therefore we don't need to check for this condition in the first place. Any other questions? Okay, if not, I thank you all for your attention, and I hope to see many of you in the wards and also in the clinics. And of course, there are other lectures and tutorials as well. Thank you.